Now let's start with the very first option, breech at 36 weeks. We saw three options. One was external cephalic version, one was a vaginal breech delivery, and third was a cesarean section. We're not going to deal too much on cesarean section, but because that is pretty much easy to make a decision, and it is like any other cesarean section, just that the way you extract a breech is going to be difficult. But your decision making skills are going to be tested as to whether you're going to allow the patient, or whether she's a suitable candidate for an external cephalic version, or is this baby actually allowed to have a spontaneous breech delivery. So let's start with the first option that you can provide to the patient, which is external cephalic version. What does ECV mean? So here, put it in very simple terms, by external rotating of the baby, you're going to make the breech baby into a cephalic baby so that it can be like any other normal pregnancy. When is the ideal time to do this rotating maneuver? So in case of a nulligravida around 36 weeks, and in case of multigravida around 37 weeks, ACOG now says that this can be attempted anytime after 37 weeks will be the ideal time. Why not earlier? Why not at 34 weeks or 33 weeks? Because when you do it at premature stage, there are chances that even after you turn to cephalic, because it is premature, the size is small, it can revert back to breech, number one. Number two, most of the time by 36 to 37 weeks, most of the breech will naturally turn to cephalic, so you're giving as much time for the fetus to naturally turn. Number three, external cephalic version has its own complications. It can lead to fetal distress or sometimes even more bigger complications such as abruption, which might require you to go ahead with an emergency cesarean section. In such situations, you do not want to be doing a delivery at an iatrogenically premature stage. So if you're doing an ECV, let's say at 37 plus weeks, and you encounter a fetal distress or abruption that requires a cesarean, you know that at least you're doing it after the baby has matured. So that is why you do it at around 37 plus weeks. Where can you do it? Can you do it in the OP? Can you do it in the procedure room, or does it require a theatre? So it can be done in labor room or any other room that has an immediate access to the OT, for the same reason that in case of any emergency that requires immediate delivery, you should be able to shift the patient immediately. Before you start the procedure, make sure to rule out absolute contraindications for this procedure. First being any previous scar on the uterus, not just LSCS but any scarred uterus. ECV has a slightly high rate of rupture, so please avoid it. Second, any kind of antepartum hemorrhage, please rule out placenta previa or any unexplained placenta previa. Of course, even if you rotate the baby to cephalic, it's a contraindication for normal delivery, so the purpose is lost. But any unexplained antepartum hemorrhage, please do not do. Any hypertensive disorder, because there's a higher chance of abruption. If the patient is already in active labor, more than 4 cm or getting true contractions, or if there is rupture of membrane, because for technical or logical reasons, you not be able to do the procedure properly when the uterus is contracting, or when the liquor is reduced, or when there is leaking happening already. Multifetal pregnancy, because there is one more fetus inside, you will not be able to have that controlled action of turning one fetus. And in case of fetal compromise like severe IUGR, or to begin with before the procedure, if the baby is already in a compromised position, please do not do an ECV. So make sure that all of these factors are not there before you do. And most importantly, if the mother already has a contraindication for having a vaginal delivery, like a severe contracted pelvis or fetal compromise and so on, there is no use of turning the baby to cephalic, because she is in any way not going to be able to have a vaginal delivery. The last reason is going to be uterine anomalies, because there's not going to be enough space for the baby to be moved around. Now, let's look at ECV a little bit in detail. How is this ECV done? So, to put it in simple terms, it's just rotating the baby through the mother's abdomen. It's external, which means that you're going to keep your hands on the mother's abdomen, feel the baby and gently turn it so that the fetus head comes down. So, is fasting required for this procedure? per se, this procedure does not require the mother to be in fasting, but because there is a slightly small chance of the mother having an emergency delivery by cesarean, usually they say avoid solids 6 hours before and liquids should be stopped 2 hours prior to the procedure. Second, make sure a skilled personnel who knows how to deal with this or how to go about this ECV is present. Make sure the theatre team is informed, the staff is informed, and the neonatologist is informed. Do an ultrasound prior to the procedure to confirm the presenting part, the type of breech, liquor amount, placenta, all of these, and if possible even estimated fetal weight before you go ahead with the procedure. And the mother can be in supine position with a slight left lateral tilt to make sure that there is no supine hypertension, or you can even put the mother in a slight Trendelenburg position so that the breech is disimpacted from the pelvic inlet. And do a pre-procedure CTG or an NST to make sure that the fetus is all right. And you can give a uterine relaxant or a tocolytic. The most commonly one used is going to be terbutaline 0.25 mg subcutaneously. Once you give this, there is going to be a slight maternal tachycardia which is going to be reflected as a fetal tachycardia as well, which means that the drug has started acting. Now you can apply certain substances like either a gel or a powder so that you get a grip on the abdomen and it's easier for you to rotate. And the rotation can be done either in clockwise or anti-clockwise direction. So if you're going to flip the head forward, like the picture that's shown here, you can see that the head is flipped forward. It's called forward roll. Sometimes they do a backward flip where the head is flipped backwards. Either way, the heads try to bring it to the lower pole. Ultrasound is used to look at the fetal heart rate in between the procedure. So you turn halfway, check the FHR, again turn. You can't completely turn it in one go. It's a series of small movements, and when you do these small movements, at the end of each of these small movements, you check the fetal heart rate with ultrasound. And once the procedure is over, once you know the head is at the lower port, always do a post-procedure CTG to make sure that there is no fetal distress or features of abruption or any other complications. If the mother is Rh negative, please don't forget to give an anti-D because external cephalic version is one of the sensitizing events. Anytime you notice any FHR changes like decelerations or bradycardia or sudden bleeding PV, please shift her for an emergency cesarean section. It can be a sign of compromise. Now, how many times can you attempt? You can attempt maximum of 3 times in one sitting at particular interval. Some institutes even do once at 36 weeks. No, if they're not able to do it, then they can do it after 2 to 3 days or after 1 week, another attempt. So after individual intervals, maximum of 3 attempts are allowed, but not more than that. At the end of 3 attempts, if you're not able to turn it, probably it means that she's not a proper candidate for ECV. So you are doing this special obstetric procedure with an intent to make the fetus cephalic, but how effective is it? So the success rate is quite good. It's 50-50 chance. It's around 50 to 60%. But there are some factors that actually increases the chance of having a successful ECV. One being multiparity, because the abdominal wall is going to be lax, which means more space for you to turn the baby. If it is a complete type of breech, because in complete breech the fetus is sitting, so highly unlikely that the breech and the foot is going to go inside the pelvis. So the breech will be floating, so it's easy for you to grasp and turn. In contrast to a frank breech where it's only the breech that's presenting, it might go and sit into the pelvic inlet snugly. You might have to disimpact the breech first before you go ahead with the procedure. Adequate liquor is very important. When there is too less of liquor, then you don't have much space to work with. When there is too much of liquor, you can't feel the fetal parts to hold and turn. The baby should not be too small or too big. Difficult, again, there's space constraints. And placenta, if it's upper segment, it's much better because there's a lot of space for you to work with the rest of the uterine cavity. So these are factors that can help in making sure that the ECV is successful. Is ECV associated with complications? Yes, definitely. There is a small chance for placental abruption, for the patient to go into preterm labor. There is a chance for non-reassuring fetal status or fetal distress, the most common being bradycardia, mostly secondary to abruption. And because of these placental abruption, preterm labor or NRFS, the patient has higher chance of going into emergency LSCS. But an absolute risk of having an emergency LSCS due to an ECV is very less. It's around only less than 0.5%. So when you're counseling the patient, it's important to let her know that such complications exist. But the frequency with which they occur is actually quite less. They can also be associated with other more severe complications, but fortunately these complications are quite rare, such as uterine rupture, feto-maternal hemorrhage, alloimmunization, and some cases have also been associated with maternal and fetal death, but these are quite rare complications. Nevertheless, the patient who fits into the criteria or who are eligible for ECV should be counseled about the success rate as well as the complications associated with ECV, and the written consent must be obtained. Now, some patients might ask you, especially in the present generation, is there any kind of exercise that I can try? Is there any other options other than ECV that will help my baby turn or to become cephalic presentation? Now, there's something called as Moxibustion, which is not exactly an allopathic treatment. This is the type of Chinese traditional medicine. This herb is ground from, or it is made into a powder from a plant called as Artemisia vulgaris. It is otherwise called as mugwort or moxa plant. And this powder is made into a thin cylinder or a cigarette-like structure, and it is lighted and it is kept at a point, an acupuncture point on your foot called as BL67 acupuncture point. It is either kept, this is burnt and this stick is kept close to this structure, or sometimes a heated needle is going to be kept on this acupuncture point. Now what they say it does is that it's going to increase fetal movements. By doing this, they say that the fetus is going to start moving, and this movement is going to facilitate it to rotate by itself. The fetus is going to undergo a version by itself so that the breech gets corrected into a cephalic presentation. Now, is this really effective? We do not know. Usually this is, if at all the patient is undergoing, it's done between 33 to 36 weeks, because if this fails at 36 weeks, at least you can try doing ECV. Different studies have been done which is not able to establish a definite effectiveness through Moxibustion. But again, there is no risk or complications involved with it. It's just burning stick that is kept close to your foot. So if the patient wants to try, she can. But whether you're, for example, in ECV, you are able to give a success rate of around 50%, but you might not be able to quote such kind of success percentage in Moxibustion. That was about the first option, which is ECV. We saw in which patients ECV can be offered, the contraindications that we need to look at, how the ECV is done, and some complications associated with it. The second option is going to be vaginal breech delivery. Now, let me stress again that in modern obstetrics, vaginal breech delivery has become a rarity unless it's the second of breech. Or sometimes when a breech presentation is missed and the patient comes in active labor or in second stage with a breech presentation, we do not usually see a vaginal breech delivery thanks to the term breech tile by Hannah. Most of the breech presentations are taken up for elective cesarean sections. Having said that, it's very important for obstetric trainees as well as practitioners to know how to conduct a vaginal breech delivery if at all you are left in a situation as such. So let's look at what it is to have a vaginal breech delivery, the steps involved, and what are the critical points in these. So in vaginal breech delivery, like cephalic presentation, there are few parameters that you need to make sure are fulfilled. First, make sure that the prerequisites are met. We saw some of the criteria that needs to be met, or all of the criteria that we saw in the initial flu slides, which included the fetal weight, the type of breech, make sure that there is no scar, and so on. So we saw a couple of criteria, make sure that all of them are met and that baby and the mother are safe to have vaginal breech delivery. you need to counsel the mother adequately about the expected maternal and fetal complication, and you need to tell her that even though we are trying for a normal delivery, there's always a chance that she might require emergency C-section. Now, every delivery we need to know certain parameters, which is going to be the denominator, which is a bony fixed point that we give for each of the presentation. In case of breech presentation, the bony point that we are going to take is going to be the sacrum. So let's orient ourselves to this picture. This is the pubic symphysis of the maternal pelvis. These are going to be the right and left pelvic wall, and you have the maternal sacrum at the back. So that's the posterior. So here you have the baby's buttocks, and this is going to be the sacrum. So the bony point that we're going to take for constriction and breech is going to be sacrum, and the engaging diameter in case of breech, because it's not the head, the bony point that we're going to look at is going to be the bitrochanteric diameter, which is around 10.5 centimeter between the two trochanters of the fetal femur. And the positions that are possible which with this breech is going to be, first is going to be right sacro-anterior. You can see here that this is the fetal sacrum. It is towards the anterior part, more towards the right of the maternal pelvis. So this is going to be, the first position is going to be, that you see here is going to be right sacro-anterior. The other position that's going to be possible when the fetal sacrum is towards the left side of the mother but on the anterior quadrant is going to be left sacro-anterior. Similarly, if the sacrum is on the posterior quadrant, here you can see that the sacrum is towards the posterior part of the mother, more on the left side. This is going to be left sacro-posterior. And if the sacrum is towards the posterior part of the maternal pelvic bone but towards the right side, it's going to be right sacro-posterior. So these are the four positions that are possible with a breech presentation. Now, let's look at the mechanism of breech vaginal delivery. We saw the cardinal movements that were involved with the cephalic presentation, which included engagement, descent, flexion, internal rotation. So you remember those steps. Such like that, even breech presentations have a similar cardinal movements of labor that it has to undergo before it is born. But the thing to remember is that here we are going to deliver the baby in three different parts. The first part that's going to be delivered is going to be the breech, second is going to be the shoulders, and third is going to be the head. So let's start with the breech presentation. Two important dictum that needs to be remembered in vaginal breech delivery. One is, don't be in a hurry, don't push or pull the baby. Second, whenever the breech is delivering, you might not have to do a lot, but always make sure that the back is facing you. So the baby should be looking down, you should be able to see the baby's back always. So the back should be anterior. Please remember these 2 points all the time when you're conducting a vaginal breech delivery. So let's start with the delivery of the breech. The first fetal part that's going to be delivered in a breech presentation obviously is going to be the breech. So here first step is going to be engagement. So here you can see that with a similar explanation, if this is pubic symphysis, that's going to be the anterior part of the maternal pelvis. You have the maternal sacrum at the back posterior, and then you have the right and the left side. Having said that, if this is the fetal sacrum, here the position you can see is going to be right sacro-anterior position. And the engaging diameter is going to be the bitrochanteric diameter, and the diameter of engagement along which it engages is going to be the left oblique line. So an easy way to remember is that in case of breech presentation, whatever the position is, the opposite will be the diameter of engagement. So if it's going to be right sacro-anterior, the diameter of engagement is going to be, or the bitrochanteric diameter is going to be along the left side, so the left oblique line. So here the first engagement occurs, that is the largest part, diameter of the fetus that enters the pelvic inlet is going to be the bitrochanteric diameter. In cephalic presentation, we have seen descent with flexion, where the baby doubles up upon itself so that the smallest diameters will descend through the maternal pelvis. Similarly, in breech, instead of flexion, we use the term compaction, because the breech compacts itself or makes itself quite compact so that it can descend through the bony maternal pelvis. And the next step, like in cephalic, is going to be internal rotation by 1/8 of a circle so that the anterior buttocks hitches against the pubic symphysis. So let's see what happens here. So here it is RSA. Now you can see that the buttocks is rotating so that one of the anterior buttocks comes directly under the pubic symphysis. And the next step is going to be the baby's body bends sideways so that one of the buttocks or the anterior buttocks is delivered by lateral flexion and the posterior buttocks is also born. Now that was about the delivery of the breech or the buttocks. Now the breech is delivered, the rest of the soft tissue up to the trunk and thorax will be born because they are all soft parts. The next bony part that needs to be delivered is going to be the shoulders. Now the shoulder is going to be engaged along the bisacromial diameter, which is the diameter between the two acromial processes. So here the same prompt, this is going to be the pubic symphysis of the mother, sacrum, right and left side. Now the breech is out. This is going to be, so you're looking at the shoulder from the top, okay? So they're going to be the baby's head still inside like this. Okay, so these are going to be the shoulders and this distance between the two acromion is going to be the bisacromial diameter. Now this bisacromial diameter is going to be engaging along the same engaging diameter as you saw in the bitrochanteric. It's going to be along the left oblique line. Same as the bitrochanteric. Bitrochanteric also was along the left oblique. Because you can see that the acromion process, two acromion process and two trochanteric process are along the same line in all of us. So the bitrochanteric diameter and the bisacromial diameter are going to be engaged along the same oblique line direction. Now this bisacromial diameter that is along an oblique line again undergoes internal rotation and the shoulder, anterior shoulder comes just below the pubic symphysis, hitches against and it gets delivered and then the posterior shoulder delivers again. The next part, the bony part that's going to be delivered, the most difficult part and the biggest part is going to be the head. So in case of head, now we saw that the shoulder is out. Shoulder was initially like this, the bisacromial diameter was along the left oblique now. So if you all notice, the axis of the head is always perpendicular to the axis of the shoulder. If you look at the length of the head is like this and the shoulder, so it's going to be perpendicular to each other. So here the head, the engaging diameter like in cephalic presentation because it's well flexed is going to be suboccipitofrontal. If this is going to be the face, this is going to be the occiput, this is going to be the engaging diameter. But here you can see that it's along this axis of the maternal pelvis. So the engaging diameter of the head will be along the opposite oblique diameter of bitrochanteric and bisacromial. So if the bitrochanteric and bisacromial engaged across the left oblique line of the pelvis, the head will be along the right oblique line. So the engaging diameter is going to be suboccipitofrontal. And now this also undergoes an internal rotation such that occiput hitches under the pubic symphysis and here the head is borne by flexion, not extension like in cephalic, but the head is borne by flexion. So these are the cardinal movements of a breech vaginal delivery. Now let me show you a more pictorial or an easier way of understanding. So here you can see that the first part that enters is going to be the breech. So here because you're seeing from side, I won't be able to draw at bitrochanteric diameter. It goes deeply like this on either side. You can see one of the trochanter, it's entering the pelvic inlet. So the first thing that enters is going to be the breech. And now the breech has undergone internal rotation such that one of the buttocks, anterior buttocks is under the pubic symphysis and the posterior buttocks is along the sacrum. And by lateral flexion, so the body bends sideways such that the anterior buttocks is born and then the posterior buttocks is born. So now the buttocks is completely out and the next thing or the next bony part that enters the pelvic inlet is going to be the baby's shoulders across the bisacromial diameter. This also goes on internal rotation such that the anterior shoulder lies under the pubic symphysis and the posterior shoulder is just below the sacral halo. And again, the anterior shoulder is born. The next part, bony part that's going to enter the pelvic inlet is going to be the suboccipitofrontal part of the baby's head. This undergoes an internal rotation and the baby's head is born by flexion. So this is a pictorial representation of how a vaginal breech delivery happens. Now, how do you manage labor for a breech delivery? What are the things that needs to be kept in mind and how is it different from a cephalic presentation? So in first stage of labor, when the patient comes in labor, in spontaneous labor with breech, one thing to remember is that make sure that all the criteria for a safe vaginal breech delivery are met. Once again, please go through the criteria. Make sure that it is in fact breech. Next, start an IV line because you do not know when she will be needed to shift it for a cesarean section or if you need any other medications to be given. Make sure skilled personnel, which involves a skilled obstetrician, a skilled neonatologist and an anesthetist. And for an obstetrician, always better to have more hands. Make sure a skilled assistant is also present. And the next point is that it is always better to have one-to-one care. At least nursing care should be definitely one-to-one. Electronic fetal monitoring is preferred compared to intermittent auscultation because there are higher chances for fetal distress or cord prolapse which might not be picked up in those acute moments in case of intermittent auscultation. And whenever there is spontaneous rupture of membrane, make sure that there is no cord prolapse. Always do a pervaginal examination immediately after rupture of membrane and keep an eye on the CTG to see if there are any changes that are suggestive of cord prolapse like sudden severe recurrent variable decelerations or sudden bradycardia. Now, if the patient wants labor analgesia, then epidural can be given. This has been proven to be safe in breech delivery and does not seem to be affecting the trajectory of a normal breech delivery. As already mentioned, induction of labor and augmentation is a very controversial topic in breech and usually they are not advocated or they are not advisable in a breech presentation. In second stage of labor, when the fetal head you're able to see through the perineum, it's called crowning. Similarly, when the breech is seen stretching the vulval outlet, it's called climbing of breech because it looks like the baby is climbing into the mother's body. And here, if she is a grand multi or so and the perineum is already lax, episiotomy is not required, but most of the time here in breech presentation, episiotomy will be very useful because you might be doing certain maneuvers. And second is, do not be tempted to pull the baby out. There should be a progressive descent of the breech with each contraction. And initially, a passive approach is enough where the breech comes down by itself without any big effort till the breech is still seen at the perineum. And then once the mother feels the urge to push, you can advise her or encourage her for an active pushing. But the second stage is usually you do not require to do any kind of maneuver except for maybe perineal support, and hands-off approach is encouraged unless you think that there's a delay in delivery or you think that you might be required to do certain maneuvers. And different criteria says different timeline for second stage in breech, but it is roughly between 30 to 60 minutes. Second stage should not cross 60 minutes. Once it crosses 60 minutes, then the prognosis for the baby and the mother starts coming down. And even certain studies say that once the second stage crosses 60 minutes and you're not able to deliver the breech, it might be a good idea to shift the patient and have an emergency cesarean section.